Hi everyone, good afternoon, and I'm Gaurvika Pipra, and today we will be discussing about the central nervous system. The contents for my presentation will be meningitis, facial palsy, facial pain, and epilepsy. Now, starting with meningitis, it is an inflammation of the pia arachnoid and the fluid contained in the space. The fluid meaning the CSF, as meninges and subarachnoid spaces are continuous over the brain and spinal cord. Hence, meningitis is always cerebrospinal. Hence, it is also called as cerebrospinal fever. Now, what's the etiology behind it? The causes, it could be infective or non infective. The infective meningitis could be acute or chronic and also recurrent. The acute infective meningitis could be caused by any microbe, whether it be bacteria or any virus or any fungal infection. So it is the most commonly seen in the clinics is the acute bacterial meningitis. Then there is also tubercular meningitis, which could be acute or subacute or chronic, and it is also very common. Talking about the bacterial meningitis, it is also known as pyogenic meningitis and arises in two ways. The first is hematogenous spread from an infected focus, and the second one is by direct extension of infection from the infected surface structures, which are the paranasal sinuses, the skull bones, ears, or any penetrating injury. The bacteriology behind is that in the extremes of age, the gram-negative bacilli are commonly encountered, while in children and adults, the infection is more common due to the gram-positive and negative cocci. So always remember that the bacilli are seen in the older ages and the cocci, gram negative and as well as positive, are seen in children and adults. Now here's a table that which type of bacteria infects what age group. Like for in neonates or infants, there's gram negative bacilli, for example, E. coli or B. proteus, group B streptococci. Then in adolescent or adults, there could be streptococci, pneumoniae, meningococcal meningitis, mucobacterial tuberculosis. Then in children, old age and immunocompromised, we have H. influenza, Neisseria meningitis, Streptococcus pneumoniae. So you can always remember like two to three and write it in the exam as well. Now, talking about the pathology, like what happens. So, there is inflammation of the pia and the arachnoid layers, which leads to acute inflammatory reaction in the meninges and exudates in the CSF. The exudate organizes and fibrosis occurs with adhesion are formed. So obstruction to the CSF flows and ventricular dilatation also happens, leading to hydrocephalus. Now, this will lead to adhesions around the cranial nerves and cranial nerve palsies will occur. There will be acute rise in the CSF pressure, which will lead to increased protein contents, and then there will be a CSF reaction. In that, there will be pyogenic meningitis, which will have polymorphonuclear leukocytes. Then, in the tubercular meningitis, there will be mononuclear pilocytosis. Then there is acute viral meningitis where there will be lymphocytosis, and pneumococcal meningitis where there will be thick purulent CSF. Now, what are the clinical features, the sign and symptoms of the infections? Okay, so there would be fever, malaise, headache, aches, pain, tachycardia, there could be treponema, vomiting, convulsions in children. And then there could be signs and symptoms of meningeal irritations. So that will be include the pain in the neck, neck stiffness, there would be positive Kernick sign and Budinsky sign. Do remember that Kernick sign and Budinsky sign could be asked in the Viva, so definitely remember those things. So there could be sign and symptom due to raise intracranial tension, for example, headache or projectile vomiting. There could be blurring of the vision, papilloedema, or any other false localizing signs and impairment of consciousness. Then there could be some signs and symptoms due to infecting organism, which could include some petechial skin eruptions or purpuric skin spots, or there could on the lower limb. Then there could be ecchymosis and skin infection due to meningococcal meningitis. Then there could be any infection associated with the lungs, ear, sinus infection in the pneumococcal meningitis. Then upper respiratory and ear infection in children could be also associated with meningitis due to H influenza. So now talking about the investigations, like what we will do to form a diagnosis. So we will see the TLC and DLC in the patient. We'll do CSF examination. So in pyogenic meningitis, that is the bacterial meningitis, the CSF pressure would be raised. Okay, the fluid will be turbid and it may contain neutrophils, which would be increased than the normal amount. The protein content would be elevated, but do remember that the sugar content would be low. So there would be gram stains of the CSF may help to detect the causative organism in some patients. Then we'll do the blood culture and CSF culture. They could be positive, but do remember that they could be false positive as well. So in X-ray, we'll do the X-ray of the chest, which would show us a patch of consolidation in the lung in the pneumococcal infection. Then moving on to the CT scan, it is always a helpful tool of diagnosis. So it could help us to diagnose the hydrocephalus and the brain abscess if they develop in any complications or as an complication. So MRI would show diffuse meningeal enhancement after gladonium. Then there will be serology of the CSF. In that, we'll see the latex agglutination test in the CSF and urine, and we'll detect the antigens for S pneumococcal and N meningitis or H influenza. We could do that as well. Then PCR tests are also commonly used to detect bacterial antigens, in which we can say gram stains and cultures, which are always like almost always negative. Then this is the management of the bacterial meningitis. We can give ampicillin and we can give penicillin or cefotaxamine. We can give the drugs shown in the table. The vancomycin is a newer agent. It is always uh, preferred nowadays. If there a person is having a penicillin allergy, we could also prefer ampicillin if the patient is having a penicillin allergy. Then the doses are mentioned in the adults and the children. We give different amount of dose. For example, talking about the ampicillin, we will give 2 grams IV every 4 hours in the adults, whereas in children and infants, it would be 300 to 400 milligram per kg per day in IV form, and it will be a divided dose every 6 hours. So moving on to the next, which is the prophylaxis. So in the prophylaxis, we can give rifampicin to children, and the dose will be obviously different according to which kind of meningitis is uh, got interacted with, or which kind of the meningitis is the patient got infected due to. So we will have the N meningitis and the H influenza. So we'll give rifampicin in children in the both of these things, and children doses like which is a child who is less than 1 month years old, we will give 5 milligram per kg. ठीक है, who is a child who is more than a year old, we will give 10 milligram per kg, and in the adults we'll give 600 milligram in divided doses like 12 hours and for 2 days. Moving on to the tubercular meningitis. The condition is commonly acquired after primary infection in the childhood or as a part of miliary or disseminated tuberculosis. The focus in tubercular meningitis is near the surface of the brain or adjacent to the pathway of the CSF. This focus is the potential source of infection or for tubercular meningitis. The pathology behind is that there is a collection of exudate at the base of the brain which interferes with the drainage of the CSF, resulting in the development of hydrocephalus. The meninges are inflamed and covered with exudate, the organization of which leads to adhesion formation. Numerous scattered tuberculae may be found on the meninges. So the clinical features which we will come across in children and in adult are different. In child, there will be fever, but in adult, we'll see a low grade fever. There could be listlessness, lethargy, lack of interest in the surrounding, anorexia, vomiting, constipation, headache, and convulsion in the children. Whereas in adults, we could see nausea, anorexia, and vomiting, pain in the neck, headache, visual disturbances, impairment of the consciousness, cranial nerve palsy, and more things. In investigations, there may be mononuclear leukocytosis, erythrocyte sedimentation rate, and these two would be elevated. The characteristic finding in the CSF is straw-colored or clear-colored CSF, which forms a cobweb in standing. The proteins in CSF are elevated, but the sugar is moderately reduced. Like in bacterial meningitis, the sugar was low. In the cells in the CSF are also increased, and mostly leukocytes and mononuclear cells are increased. It is very difficult to isolate tubercular bacilli in centrifuge specimen of the CSF. So CSF can be cultured on appropriate media for acid-fast bacilli. Now there will be serological or biochemical tests, and we'll see that there is adenosine desaminase level in the CSF. We'll see antibodies to AFB in CSF, then there'll be M tubercular antigen in the CSF. We can do ELISA for that. We can do a PCR test. Then there could be CT scan and MRIs could be done to show hydrocephalus and thickened meninges and multiple tuberculomas. Now, the treatment for tubercular meningitis. So we'll give the tubercular drugs, which are the isoniazid, rifampicin, pyrazinamide, streptomycin, ethambutol. These are the first line drugs which we usually give. And then there are fluoroquinones, which would include levofloxacin, ciprofloxacin, or moxifloxacin, gatifloxacin. We could also give corticosteroids, which will include dexamethasone, or we can give prednisolone. So, talking about the aseptic meningitis, which is also known as viral meningitis. So, it is caused by viruses. So, it is a benign and self-limiting illness. Do remember that it is a self-limiting illness. It does not require any specific therapy. It is less serious than bacterial meningitis, and there are a number of viruses which causes it. For example, there could be herpes simplex, HIV virus, EB virus, Coxsackie virus, polio virus, but the most commonest being the echovirus and the mumps virus. So the clinical feature of this disease is that there could be acute onset of fever, like sudden onset of the fever. So there would be headache, vomiting, irritability, followed by any signs of meningeal irritation such as neck pain and neck stiffness. The fever is high grade and intermittent. There is no focal neurological sign. So, talking about the investigations, the CSF findings differ from other types of the meninges. So, there is no change in the protein and sugar content in the CSF, but the characteristic finding is the lymphocytes. And the treatment for this is that it is symptomatic, as we talked about earlier, that it is a self-limiting disease. There will be recovery within some days. We can give analgesics and antipyretics, which would be helpful to relieve pain and fever. And do remember again that it is a self-limiting illness. This could be a Viva question, so do remember that. Now, talking about the fungal meningitis. This usually occurs in patients who are immunocompromised or have a focus of fungal infection elsewhere. So it is recognized complication of HIV infection. Cryptococcus neoformans is the most commonest causative fungus, followed by Candida infection, which causes fungal meningitis. So the coccidios imitans, histoplasma capsulatum, and blastomyces determitis can also rarely produce meningitis. The clinical features and CSF findings are basically similar to tubercular meningitis. The diagnosis is made by culture or recognition of spores in the CSF and specific serological tests to detect the antigen. The treatment is amphotericin intravenously or flutocin orally. Now, talking about the facial palsy or is a condition of the paralysis of the seventh nerve. The facial nerve, seventh cranial nerve, is a mixed nerve and it supplies all the muscles of the face concerned with expression. The sensory part carries sensation from the anterior two-thirds of the tongue through chorda tympani. The nucleus of the seventh cranial nerve lies in the pons. The fibers of the facial nerve hook around the sixth nerve nucleus in the pons and then it comes out of the pons at its lower border. After leaving the pons, it enters the internal auditory meatus with acoustic nerve, the eighth cranial nerve, passes through the middle ear and comes out of the skull at the stylomastoid foramen, from where it passes behind the parotid gland at the angle of jaw and subdivides to supply facial muscles. Now, this was the course of the facial nerve. This is very important. It could be asked in the Viva, and you could write it in the theory exam and score more marks. Now, the site and causes of the facial nerve. So there are like different causes at the different sites of the facial nerve, like where the lesion, if the lesion, if it is at the pons, it is at the pons level, there is a pontine lesion, it would be involving the seventh nerve, and it will not spare the sixth nerve and the corticospinal fiber, which would lead to cross hemiplegia. It is also known as Miller-Gubler syndrome. So, if the lesion is at the cerebropontine angle, it will be affecting the seventh nerve along with the eighth cranial nerve. And due to that, there could be tumors like acoustic neuroma or meningioma. Then the symptoms would include deafness, vertigo, tinnitus, and facial nerve palsy, obviously. At the middle ear, the lesion could cause loss of taste over the anterior two-thirds of the tongue. All the parts of the face are affected. If the nerve to the stapedius muscle is also involved, the patient experiences hyperacusis. Then, if the lesion is at the supranuclear or infranuclear paralysis, the supranuclear is also known as the upper motor neuron, and it would cause contralateral lower facial paralysis with forehead which would be spared. And in the infranuclear lesion, there would be ipsilateral paralysis of the entire face. Now, talking about the supranuclear and infranuclear lesion. So, in this, the supranuclear is also known as the upper motor neuron lesion, and the infranuclear lesion is also known as the lower motor neuron lesion. Now, this is important as you could be asked a question in the theory or in the viva. So, you should know the difference between this. So, basically, in the supranuclear, the patient can make furrows on looking upwards, whereas in the infranuclear, the furrows are lost on looking upwards on the side of the face affected. And in the supranuclear, the lesion is above the pons level, whereas in the infranuclear, it is in the pons or in the pathway from the pons to its exit. So, in the supranuclear, there would be isolated involvement. The isolated involvement of this type is rare, and in the infranuclear, the isolated involvement or the isolated lesion is quite common. In the supranuclear lesion, it is invariably associated with the hemiplegia, like there is uncrossed hemiplegia, whereas in the infranuclear, there is crossed hemiplegia. So, this is the chart or diagram, you can say, explaining both of the lesions. Now, talking about the idiopathic palsy, or also known as Bell's palsy. So, it is most commonly seen palsy of the facial nerve. Okay, and it is mostly unilateral and idiopathic. Like we don't know how it arises or what's the cause behind it. So, usually, this disease affects the patient of both sexes and all ages. The site of the lesion is the labyrinth portion of the facial nerve within the facial canal or at the stylomastoid foramen. The swelling of the nerve or nerve sheath at the site has been observed, which may compress the nerve and interrupt its motor supply to the muscles of the face or on the involved site. Now, the precipitating factors, like we think, like what will be the factors causing facial nerve palsy or Bell's palsy, basically. So, it would include viral infections like herpes simplex or herpes zoster. Now, there could be vascular damage, there could be trauma, cold exposure, pregnancy, and diabetes mellitus. So clinical feature, what we will see in the patient. The onset, the patient will come with the history and he'll say the onset is acute or subacute, and where basically subacute is the most common. So the maximum involvement occurs within a day or two. The patient may complain of abrupt onset of the pain, like behind the ear or on one side of the face before asymmetry of the face is noticed. Sometimes patient even complain of numbness on the side of the face, but there is no objective sensory loss. Occasionally, loss of taste sensation over anterior two-thirds of the tongue may be experienced. Hyperacusis occur if there is involvement of nerves to stapedius muscle, and severe lesions may cause loss of saliva and tear formation. And the patient might not notice the facial palsy. It could be noticed by a family member or a friend. So, what will be the management? The disease is benign and it is self-limiting, and recovery is the rule. A complete recovery can be expected within 4 to 12 weeks, and it is more than in 75% of the patients. So, treatment is symptomatic. The surgical decompression is not attempted usually because majority of the patient recover well without any interference. We could also give some application of soothing agents such as calamine cream or lotion, antiseptic powder containing providine, lodine may help to limit the secondary infection. For immunocompromised or elderly patients with severe disease, hydroxyzidine 20 to 40% in DMSO may be applied to the affected dermatome on dressing whenever practical. We can also give antiviral drugs such as acyclovir, which is given as 800 mg orally 5 times daily for 7 days to all the patients with herpetic infection. We can also give famciclovir, uh, uh, and it is also affected and is given 1 gram 3 times a day. Acyclovir creams are also available and can be used for local purposes and for less severe disease. Then there could be steroids, which can also be given. For instance, prednisolone can be given in dose of 40 to 60 mg, decreasing over 3 weeks, can prevent post-herpetic neuralgia in those over 60 years of age. Then there could be dissemination of the disease, which is not seen with systemic steroids. The combination of steroids with acyclovir is better than either alone. Now we can also give carbamazepine or phenytoin or gabapentin. There could be protection for the cornea by wearing glasses or adhesive paper tape to hold the lids. We can also give antidepressant at nights, which could be useful as well. Now, talking about Ramsay Hunt syndrome, this is very important, could be asked in the Viva and also in the theory. So it is just come as it might come as a short note, but basically it's a Viva question. So this is due to the herpes zoster infection involving the geniculate ganglion, and the features include facial palsy, which is identical to Bell's palsy, herpetic vessels in the external auditory meatus, which receives a sensory branch from the facial nerve, and deafness may occur. Now, talking about facial pain. Trigeminal nerve is a sensory nerve for lace. Therefore, intimate lesion of fifth cranial nerve or its branches may lead to facial pain. Sometimes pain may be referred from other sides, such as from teeth, TMJ, ears, etc. There could be atypical facial pain can occur without any reason. Now, the causes of the facial pain would be trigeminal neuralgia, postherpetic neuralgia, migrainous neuralgia, psychogenic, tempomandibular arthritis, and malocclusion. Now, trigeminal neuralgia, it is also known as tic douloureux. This is a very important topic. So, the neuralgic pain or facial pain occurring in the territory of trigeminal nerve is termed as trigeminal neuralgia. It is mostly idiopathic, but in some cases, an apparent loop or artery may press on the rootlets of trigeminal nerve as they emerge from the pons. It occurs commonly in middle-aged or elderly people. Occasionally, it may occur in younger patients and mostly affects women more than men. The cause in the majority of patients is unknown. So these are the symptoms of trigeminal neuralgia. So the most common are like unilateral pain, and less common is bilateral pain. It is most commonly occurring in one or more trigeminal branches and less commonly radiates to the ear. The quality of the pain is like the patient will complain of a stabbing or electric shock like pain, okay, and can occur without the pain can occur without warning. The intensity of the pain will be very severe. So the duration of the pain it could be less than or equal to 2 minutes, and if it's a lot, it could also increase to more than 2 minutes and occur for a few minutes. There would be abrupt onset and termination of the pain, or the patient could be also experiencing pain free attacks as well. So, accompanying symptoms on the affected side would be that there is continuous pain of moderate intensity, or muscle contraction can be caused by very severe pain. There could be lacrimation or redness of the eye. The management will include medical treatment and surgical treatment. In medical treatment, we could give the patient phenytoin, gabapentin, carbamazepine, and other drugs. And in the surgical treatment, there could be an alcohol block could be given, cryotherapy could be done, neurectomy could be done, radiosurgery could be done. There could be gangliosis as well. Talking about post-herpetic neuralgia. So there is in the patient there is a history of herpes zoster infection and over the face with typical vesiculopapular lesions. Dermal scars of the herpetic infection may be present. It is unilateral and may involve any division of a trigeminal nerve. The pain is in the form of ache or burning, which sometimes is severe. Pain is also increased by any contact or movement. Paresthesia and slight sensory loss may be present. Treatment is carbamazepine, phenytoin, and antidepressants. It may subside after some time. Now, epilepsies. So, epilepsy are a group of disorders of cerebral functions characterized by chronic recurrent seizures due to chronic underlying process, hence called seizure disorder. Seizure is defined as an episode of abnormal synchronial neural discharge in the brain. Convulsions are seizures accompanied by motor manifestations, that is, limb jerking and incontinence, etc. Seizures need not to be always convulsive, it may be manifested by other changes in the neurological function, which could be sensory, cognitive, emotional events, etc. Now, epilepsy is a most common seizure disorder affecting 0.5 to 2% of the population, and they can occur at any age. Now, the primary we will see the international classification of the epilepsy. So there would be primary focal seizures, primary generalized seizures, and could be focal or generalized. In primary focal seizures, they are divided into three types: simple focal seizure, complex focal seizures, and focal seizure with secondary generalization. So talking about the first, they could depend on the concomitant signs. For example, they would be with motor symptoms, sensory symptoms, visual symptoms and signs, okay, visual field signs, psychomotor and temporal lobe signs. In complex focal seizure, it will depend on the area involved due to the spread, which could be the temporal lobe or the frontal lobe. And in the focal seizures with secondary generalization, we could say tonic and clonic or tonic-clonic seizure. Now, the second type is the primary generalized seizure. They could be of the tonic or clonic, tonic-clonic, which is also known as grand mal seizure. Absence seizure may be typical or atypical. Akinetic seizure, monoclonic seizure, infantile spasm. And the third type includes the epileptic spasm. Now, the pathophysiology behind epilepsy is that there would be neurons which would discharge synchronously under the influence of excitatory and inhibitory system. Drugs which block GABA receptor provoke seizures. Then there would be reduction of inhibition, which may follow excess excitation to develop. Now, there would be, due to this excitation development, an abnormality in the GABA inhibitory system. Both reduction in inhibitory system and excessive excitation play a part in genesis of seizure activity. Now, the focal seizures. Focal seizures are usually associated with structural abnormalities of the brain. They can occur with many neurological manifestations that are motor manifestation, sensory manifestation, versive or visual field signs or manifestations, visual manifestations, psychomotor or temporal lobe manifestations. Talking about the grand mal or tonic-clonic seizure, it is a common type of epilepsy seen in the clinical practice. If epileptic activity has spread from a focus by secondary generalization, then there is an aura during which the patient may recall the symptoms of focal discharge before lapsing into unconsciousness. The phase which can be recognized during grand mal seizure are prodromal phase, oral phase, ictal phase, and post-ictal phase. In prodromal phase, the patient feels uneasiness or irritability lasting for hours or days before an attack. When the oral phase occurs, there could be visual hallucinations, nausea, epigastric discomfort, alteration of psychic functions, deja vu phenomena, jerking of one limb, etc. When the ictal phase occurs, there could be tonic contraction of the jaw muscle, flexions of the arm, extension of the leg. A cry due to spasm of laryngeal and respiratory muscles occur during tonic phase, lasting for 10 to 30 seconds, followed by loss of consciousness. Now, there is also a clonic phase during which there is violent jerking of the face and limbs, biting of the tongue, and incontinence of urine and feces, and it lasts for 1 to 5 minutes. Now, talking about the postictal phase, there is deep unconsciousness with flaccid limbs, loss of corneal reflexes, lasts for few minutes to several hours. There may be postictal headache, confusion, automatic behavior, and violence as well. Now, classical absence seizures or petit mal seizures. This form of epilepsy is typically seen in children. During an absence attack, a child stops working, looks confused, stares in space, may blink or roll up the eyeballs, and fail to respond to verbal commands. The attack is very brief, lasts only for several seconds, but many such attacks may occur during the day. If attack occurs during standing position, many children even may fall but are able to get up again without difficulty. This type of attack is called akinetic seizure. Children with typical absence attacks develop tonic-clonic seizures during adulthood. Now, these kinds of attacks may also be presented by the teacher to the parents of the children as the child is in school, and these kind of attack may occur, like he or she could be staring at the whiteboard or something and would not respond to the teacher calling out his or her name. The typical absence are always seen in idiopathic epilepsy, which starts in childhood or adolescence. EEG shows spike and wave complex at a frequency of 3 Hz per second. These discharges are provoked by hyperventilation. Classical absence are always due to developmental or genetic abnormalities of the neural control. They have a less abrupt onset and have long duration of unconsciousness, have more obvious motor signs, and are usually associated with neurological dysfunction such as mental retardation. Now, the precipitating factors include insomnia, stress, pyrexia, physical or mental fatigue, drugs, infection, flashes of bright light, alcohol ingestion or withdrawal, menstrual disturbances, loud noises or music, reading or writing as well. The causes we can learn it from a mnemonic, which is vitamin D and E. I have wrote it down. These causes are of epilepsy. So the causes include vascular discharge. V stands for vascular changes, stroke, subarachnoid hemorrhage, press, anoxic injuries. I is for infection, including meningitis or encephalitis. T includes trauma. It could include head injury, extradural hemorrhage. Then A stands from autoimmune. M stands for metabolic causes like hypoglycemia, hypocalcemia. I again is for idiopathic, it could be genetic. Then N is for neoplasm, B is for drugs, and E is for electrolyte imbalance. Now, the investigation. We can do some general investigation, which could include the blood work done for the patient or complete hemangiogram, and there could be LFTs done, then there could be serological test for syphilis and HIV. The EEG is done, and EEG shows high voltage, fast transient spike and waves during or in between the seizures. Then CT scan is done. In CT scan, we could find out some structural diseases like granulomas or tumors. Then we could also do MRI or PET or SPET. These are usually useful for early evaluation of the focal seizures. We can also do a lumbar puncture, which is done to rule out any infectious cause as well. Now, talking about the management, we will be giving anti-epileptic drugs to the patient, which would include phenobarbital, phenytoin, carbamazepine, sodium valproate, clonazepam, nitrazepam, diazepam, ACTH. These drugs are given for different type of epilepsies, and different doses are there for adults as well as for children. The drugs also come along with some of the side effects mentioned in the table. So, the dangers during a seizure and how we can help a patient. If you see someone uh, experiencing a seizure or an epilepsy attack, you first need to uh, isolate the patient and remove anything which is covering his neck, loosen his or her clothes, maintain a secure airway. There could be difficulty for the patient to breathing. Ask for help if someone is trying to put finger inside the patient mouth. Don't let that happen, and ask the person to call for ambulance or something, and ask for help. Definitely maintain the airway, talk to the person to ask for help, and you have to uh, turn the patient sideways. Now there is something called as triple S, which is stay safe and side. You have to stay with the person until the seizure is over. You have to keep them safe from the surroundings. Okay, you have to turn them to a side if they are unconscious. And if you witness someone having a seizure, just don't panic. If it is their first one, they do not wake up after a few minutes or they appear not to be breathing. So definitely call an ambulance. So that is it. Thank you for so much.